My thanks. My thanks to everyone who's joined us. We're going to give about 60 seconds for everyone to get into the webinar, and then we'll get started. Hello and welcome. My name is Sarah Emond, and I'm the President-elect of ICER, and it's my pleasure to welcome you to our webinar today, where we'll be discussing the updates we recently made to our value assessment framework. Next slide, please. I have the distinct pleasure of being joined by several of my esteemed colleagues today. Today, we will hear from Felusha Agbula, our Vice President of Research, Kat Kula, our Director of Patient Engagement, and Steve Pearson, ICER's President. The agenda for today on the next slide is to reflect a little bit on the previous value assessment framework, what it included, the impact it's had, and next we'll talk about the goals for the 2023 update, and each of our team members will walk through some of the key changes we've made. To get us started by reflecting backwards, it's my pleasure to introduce Steve Pearson.
Thanks, Sarah. And welcome to everybody on the webinar. So ICER has been having some version of a value framework dating back almost 10 years now, at least. But we formalized it first in 2017, then had another 3-year kind of formal process with an update in 2020. And this is our second major update. The overall purpose from the very beginning has had at least 3 different important goals. One is to make sure that we are as transparent and as explicit as possible on how we are going to evaluate value. What are the terms that we're going to use? What are the quantitative? What are the qualitative elements? Because we want to both make sure that the rules of the road are clear so that people can understand our approach, but even more importantly, in some ways, make sure that they understand where they do participate, where our hope and need for their input is absolutely critical to our approach to trying to make sure we provide a comprehensive view on value for decision makers. So at the lower left-hand corner, you can see a really important part of that is to describe how we seek to incorporate patient experiences and values in our report and in the public deliberation at our meetings. And we try to make sure that we frame this overall effort in a way that people who aren't that familiar with health technology assessment can understand, again, where we fit into the ecosystem. So, for instance, we're really trying to make sure that we're focused on thinking about the population level focus, because ultimately our work is frequently used to guide coverage decision-making kind of parameters, price negotiation for a single price over a very broad population. And it's not meant to do the very important work of trying to provide individual patients and their caregivers and clinicians information to guide their individual decision-making. So we are not about trying to intersect with the patient-doctor relationship and create decision-making guides or tools at that level. So we try to make that clear, again, as part of the broader goal that we have for the value assessment framework. So since 2020, just in terms of, I guess, activity or output, you can see here we've had 35 assessments, 56 total publications, including policy papers. Those assessments have included not just drugs, but for the drugs, there have been 85 new drugs, over 17,000 final evidence report downloads. In creating this material, we've engaged with well over 100 patient groups, individual patient representatives, and caregivers. And our report at a glance, which is the executive summary version of our work, has had over 6,000 downloads. Now that's kind of like the nuts and bolts of what's been happening and some process. But even more on the process side, since 2020, we have continued to engage with the participants in the healthcare system. What's working well with our reports? How are they being understood? How are they being applied? How are people feeling about their ability to engage and share and be respected and have their voice heard through this process. And we obviously in our public meetings get our own kind of laboratory experience with how some of our approaches are working, and we learn a lot from those as well. So over 3 years, we do gain a lot of input. And we also want to welcome and thank the, I think it was 32 patient and industry organizations that submitted comments, formal public comments to us on our draft version of the 2023 framework. But we have had many, many other informal conversations and experiences as part of our learning. So we can't cover the entire territory in the value assessment framework update that you can find online. But we're going to focus on some key elements of what we are doing going forward. We're going to start with an overview of what's happening in the patient engagement process, including activities that we're taking to improve accessibility and inclusivity. We're going to talk about our Share Your Story initiative and the new ICER Patient Council. Under the overall kind of rubric of health technology assessment methods related to health equity, we're going to talk about our approach to doing analyses of clinical trial diversity and thinking about when and perhaps when not to do specific analyses of racial and ethnic subpopulation effects. We're also going to talk about the quantitative measures and qualitative that we incorporate in the discussion and voting on unmet need as one part of health equity. Now, cost effectiveness is frequently a hotbed of input and controversy in some ways because the methods in any academic field are constantly evolving, and yet there are reasons to sometimes go fast and sometimes go slow. So we're going to talk about our approach, mainly the changes this year related to our non-zero input into our societal perspective around productivity. I'll mention our approach, our final approach to dealing with what can be called dynamic pricing as part of a scenario in cost effectiveness, and then a guide to our future methods development on the different value domains and potential modifiers of value that academics and many policy people have been talking about. So with that, we're going to dive in, and I'm going to hand it over to Kat Kula. Kat.
Perfect. Thank you, Steve. Hi, everyone. For those who I haven't had a chance to meet yet, I'm Kat Kula, and today, next slide, please. We have 6 main updates to ICER's patient engagement program. So I'll walk you through those updates and reflect on the feedback we received during the public comment process. Next slide. So as Steve mentioned, we have the Share Your Story Forum initiative. So those who have engaged with ICER way back in the past, you may remember our patient and care partner input questionnaire. So this is meant to serve as a version 2.0 of that form. The old form was very long, it was not very patient friendly. So this new version is meant to distill all of the questions from the old form into 5 main aspects that we are most curious to learn about early in the review process. So things such as, what is the impact of the condition on daily life? What is the experience with treatments, experience with accessing or affording care, hopes for a new treatment, and the impact on family and caregivers. So all submissions to this form are anonymously incorporated into our assessment. However, there is an option at the end of the form to opt in for the ICER team to reach out via email if you're open to a call with our team. And this new form is meant to be disease agnostic across all of our reviews and serve as an additional form of written input for those who are unable to join us on a scoping call. So I know we received a lot of comments and questions about, this is not really a validated survey tool, and that's correct, but it is one additional way for us to gather patient input as we put together our research plan. So we are hopeful that this new form achieves our goal of being more accessible and allowing for greater participation into our process. Next slide, please. So we received a lot of positive feedback on this new addition, our small group discussion, to our process. So during the scoping and draft report development phase, ICER will now be partnering with the patient community to recruit for these small group discussions with the goal of increasing diversity of patient participation. So these group meetings really allow us to speak with a much larger number of patients and caregivers than we have in the past, and also increase the geographic, the racial, and the ethnic diversity of patients that we speak with, which I know is also really emphasized in the public comments. So all of the insights that we gather from these discussions will then be summarized into our patient perspectives chapter of the report. Next slide. The next few updates also really align with our proposed best practices in HTA that support health equity that we had published in our white paper earlier this year. So we know that in order to address financial barriers that may hinder the inclusion of patient participation into our process, it would be important to compensate patients fairly for their time. And so, and at a rate that's comparable to other stakeholders who are engaging with us. So we're excited to be able to formalize honoraria for select activities, specifically the most time-intensive ones that I've listed here. And I did also want to note that we were able to use the National Health Council Fair Market Value Calculator to help inform these rates. Next slide. Our updates to the public meeting format also help address some of the more logistical or communication barriers that may exist for patient engagement. So with regard to the public meeting, we will continue to offer virtual attendance and remote testimony, and now also offer closed captioning for those who are unable to follow along with the audio. And so we were happy to see all the positive feedback on these changes, as well as our commitment to patient compensation. Next slide. In terms of ICER's Patient Council, many of you may have seen our public announcement earlier this summer about the launch of our Patient Council. This has been in the works for a while, so I'm especially proud to be able to include this in this year's BAF update. We have spent the last year working with this council and co-creating an action plan with objectives for what we intend to work toward. And so we plan to identify opportunities to improve ICER's patient engagement process, to ensure the diversity of patient participation, and to ensure the accessibility and inclusivity of our materials. So with the council, we've established a roles and responsibilities agreement and committed to a 3-year term for each council member. So we currently have 6 members who come from diverse patient advocacy backgrounds with varying levels of experience with HTA, and we believe that this will be a great strength of the council. I know that through the comments, we received a lot of requests for greater transparency around the goals of this council. So I did want to point out that on our patient portal online, we do have a dedicated page to our council where you can read about these objectives, and I'll link you to all the bios of our members. Tiffany Westridge Robertson will serve as the co-chair of the council from the patient side, and I will serve as the co-chair from the ICER team. So we plan to meet quarterly over Zoom and once in person for an annual summit. So as soon as we have any developments to share, we plan to feature those updates on our dedicated webpage on the patient portal. And again, we've received so much support and so much interest in our council, not just through the VAF comments, but also following our public announcement. So I'm very excited to see what the future holds. Next slide. And finally, we received a ton of comments from almost every type of stakeholder in the public comment process. We heard loud and clear that ICER needs more patient-friendly resources. So based on this feedback, we were able to include a 6th update to our program, which is our commitment to create guides and summaries of our process and research reports. And we hope to co-create these materials with the patient community when appropriate, and also have the patient council weigh in on these resources as well. So I've included snippets of some of our recent guides here. The 2 on the left walk you through different phases of ICER's review process, while the 2 on the right are summaries of a drug report, as well as the white paper on health equity that I had mentioned earlier. So all of these guides live on our patient portal or on our website, and we hope to direct the patient community to the relevant guides during the review process. So I'm sure there's still a lot of room for improvement, and we welcome the community's feedback on these guides. This is going to be an ongoing evolution of our materials, but I'm really excited to be able to offer a bridge between the very technical aspects of ICER's work to a version that allows us to share our findings in a meaningful way with the community. So with all of these updates, thank you all for those who provided comments in the VAF process or feedback. Over the years, I attribute almost all of the growth of our patient engagement program to those who have been on this journey with us. So thank you. Next slide. With that, I will hand it off to Felucia, who will walk through the next portion of this webinar.
Thanks, Kat. Good morning, everyone. I just want to again thank all the people in the various groups that provided very thoughtful feedback on our VAP updates. I will be highlighting some of the updates we made to our methods that are related to health equity. Next slide, please. Specifically, I will be discussing what we are now going to be doing on clinical trial diversity and some of the updates we made to how we are approaching subpopulation analysis, and a new subsection we are going to be including in our report on patients' input on clinical trial design. And then I'll pass it on to Steve to take on that last bullet point I have here on quantitative measures to guide discussion and voting on unmet need. Next slide, please. We are now going to be including clinical trial diversity as a new subsection in our report. And the goal is to promote conversations around equity in clinical trials of new drugs. This section will be used to capture information on relevant demographic characteristics of participants in the clinical trials of interventions that are included in our reviews. In addition, we are going to be rating each trial on diversity related to race and ethnicity, sex, and age. For age, we're going to be specifically evaluating the inclusion of older adults in clinical trials. Now, for us to be able to do this objectively and consistently across all ICER assessments, we have developed a tool for evaluating clinical trial diversity. We developed this tool based on recommendations that came out of our white paper on advancing HTA methods that support health equity. I want to acknowledge the extensive input we got from stakeholders that served as members of our Health Equity Advisory Group in developing these recommendations. In the process of this VAP update, we received several comments back from stakeholders on the importance of aligning our methods with what the FDA is currently doing in this area. I want to emphasize that we have closely been following FDA's effort in this area. And in fact, the backbone of our approach stems from what we have seen in the FDA guidance. For example, we use the prevalence of the disease condition as the benchmark for evaluating clinical trial diversity based on the guidance FDA laid out in 2022, which stated that clinical trial developers should use the epidemiology of the disease as the enrollment target. We have expanded on this by defining thresholds to describe adequate and inadequate representation. And the thresholds we define accounts for the limitation of those prevalence estimates. Ultimately, the goal will be for us to rate each trial as either good, fair, or poor on diversity related to these characteristics. We know the one potential challenge of implementing this framework is how we handle multinational trials, particularly when we're evaluating race and ethnicity. We received conflicting comments from stakeholders on how to approach multinational trials in general. While some stakeholders strongly supported limiting the evaluation of racial and ethnic diversity to patients enrolled in the US, others were concerned that these may penalize global trials that attained representation on the global level. Since our approach seeks to promote conversations around equity of new drugs in the US, we are going to be rating the subpopulation of patients that are recruited in the US. However, we're still going to be providing information on the racial and ethnic diversity of the overall patient population as context as needed. Now, we know that in most cases, we may not have this data of the US subpopulation in published trials, so we are going to be relying on manufacturers to provide us with this information as part of the written data request we send out. Next slide, please. On subpopulation analysis, this is the second area I'll be touching on. This is not new to our methods at all. ICER assessments have always included considerations for subpopulations in our review. However, based on our learnings from the white paper we did on advancing HTA methods that support health equity, we thought it was important for us to even take a closer look at our approach in this area, and so that we are consistent in how we're presenting information around this. At the start of every review, ICER will now be considering race, sex, and age as a presumptive subpopulation of interest. We will continue to conduct targeted literature review during our scoping phase, consulting with various stakeholders, including patients, clinical experts, and manufacturers to determine the relevant subpopulation for the review. Now, information that we gather during scoping may lead us to conclude that further consideration of subpopulations defined by race, sex, and age is not warranted for that review under consideration. This would also be the time that we get information about other relevant subpopulations. In all cases, to ensure that our reviews focus on evaluating the most relevant subpopulations, we will include a list of the subpopulation of interest and the scientific rationale for evaluating the subpopulations in our scoping documents and research protocol. Now, in cases where subgroup effects are encountered, we have also introduced a new tool that would allow us to be able to evaluate and present information on the credibility of subgroup findings to ensure clarity and consistency in how we report these findings. Next slide, please. The third area I'll be touching on is on the patient's input on clinical trial design, which is now going to be a new section in our report. And the goal here is to highlight industry-leading practices in incorporating patient perspective into the drug development program. We will now start including a written description that we receive from manufacturers on patients' input on clinical trial design. We're going to encourage manufacturers to describe the methods that they've used to collect patients' experience and how they identify the outcomes most important to patients. Thank you again for listening, and I will pass it on to Steve to take it from here.
Thank you, Felicia. All right, so I'm going to talk about methods to capture and integrate what we are now calling benefits beyond health and special ethical priorities. And I could have talked about this under the cost effectiveness section, but it absolutely also works under health equity, because some of the special ethical priorities that we have in this country and hopefully all countries is to try to figure out how we consider health gains in a way that can improve our approach to health equity overall. So here we are with these two different kinds of concepts: benefits beyond health and special ethical priorities. First off, again, this goes back in ICER's work since our beginning. We have wanted to acknowledge and incorporate broader elements related to value that may or may not be quantifiable, and that in some ways really do sit outside of what is captured in the clinical trial data or the cost effectiveness analysis. Now, not always. So I'll talk about some of those connections. For several years, at least, we had called the special ethical priorities contextual considerations. That's a term that has been used by a variety of other groups, but we have learned in listening to patient groups in particular that seemed dismissive, that there was something that contextual meant it could be forgotten about or not as important. So we've decided to change that term to special ethical priorities. Again, we wanted to, from our experience over the past few years in which we did have material in our reports and voting questions related to equity, we still felt like we needed to do a better job of trying to capture the potential impact of treatments on health equity. So that was an area we thought we needed to try to improve. And also, again, largely through our own experience in our public meetings and with comments from others, we're always working towards a better consistency and transparency in the way that we deliberate and vote on these issues. So here's what we're moving to. We've had different types of votes in the public meeting structure. Some yes, no, some, high versus low. We're going to move to a 5-point Likert scale voting of relative agreement with statements that regard the following elements that are important in making judgments regarding the overall value for money of new healthcare interventions. And we've highlighted 4. So this is the old lumping splitting issue that we've faced with these issues over time. But we think that this, and we've kind of pilot tested this a bit already, that we think it's going to do a better job of being, in a sense, cleaner messaging around the importance of some of these issues for the ultimate decision makers. Now, obviously, some of them, everyone should make their own judgment because some of these are value judgments. But an important part of our reports and process has always been to really draw out a more public conversation around some of these kind of elements that can modify the way that we think about value. So 1 to 5, relative agreement. Is there substantial unmet need with current best available treatments? We are going to return to a small effort we had tried before to use a quantifiable measure of health shortfall. Basically, that just looks at the lifespan of people living with a condition with the treatments that we have available and saying how much health, that's both length of life and quality of life, are they missing out on due to their condition? And health economists call that a shortfall, and you can both do an absolute amount of health shortfall over the lifespan or a proportional amount in terms of when the diagnosis is made and how much time is left in a patient's life. But these are not determinative of whether there is or isn't unmet need, but we think that it will help bring some consistency and, again, maybe some, hopefully, transparency to the way that people think about unmet need and begin to weigh it more tangibly into their thinking around cost effectiveness and ultimately a fair price value for money. The other thing we're going to ask that's obviously very central to equity is whether the condition has substantial relevance for disadvantaged communities. Now, disadvantaged, again, you can use different terms, but it's meant to be broad enough for us to include racial and ethnic situations in which the condition might have very high prevalence, for instance, compared to the rest of the population. But it could be regional disadvantages or rural versus urban. It could be different kinds of communities that have faced or are facing discrimination, disadvantage in different ways. Now, we have been using this calculation that we call the Health Improvement Distribution Index, or HIDI for lack of a better acronym. And again, we do not intend to say that this is the one way that you should try to measure whether a condition has special elements related to equity. There are all different kinds of issues there related to access and discrimination, et cetera. The HIDI is a relatively simple calculation, though, that just puts the prevalence of the condition in that community that we're focusing on compared to the prevalence in the overall population. And you get a relative score that obviously goes up if it's much more prevalent in the particular community that we're talking about, and could even be below 1 if it's less prevalent. So we're going to just, again, continue to include that and highlight it so that our appraisal committee members and, again, ultimate decision makers can start to figure out, how they are going to take concrete steps to integrate this kind of consideration in their evaluation of healthcare technologies and healthcare systems. Now, moving more to the benefits beyond health, and by health, again, we frequently mean what we can measure in the clinical trials, is the impact on caregivers' lives. We've had elements and a voting question related to this before, but we think this will be a cleaner way to get this issue highlighted in the final report in particular. So obviously, we're going to have previous testimony and conversations and hopefully data. It would be great to get data on that from clinical trials, and we continue to push and advocate for that to be incorporated in clinical trials. But where that hasn't happened, we hope certainly to get information, quantitative and qualitative, from patients and their caregivers. And we are going to include that as a separate vote to make sure that we highlight that issue, again, that can sometimes maybe be talked about, but may unfortunately be given second-class status in some ways in people's thinking. Last, in the formal list, we're going to ask whether there is a mechanism of action or of delivery. Of delivery means maybe this is a pill as opposed to every other option, which is a complicated intravenous regimen. Is there something about that mechanism, either of the action or of the delivery of the new treatment, that could improve access? And again, what we want to do is try to throw a broad net around this so that we can talk about specific ways that a new treatment could really help, not just on the kind of patient-by-patient improvements, but more broadly. Will this allow us to treat more patients in more locations? Will it help patients, kind of take their medication through what would otherwise be a very complicated set of hoops? So we're going to try to do that. Now, just to highlight again that this list of 4 is what we're going to be having in every report and every meeting, but we're always going to have an other. And that is something that we're going to address with patient groups, the manufacturers, clinical experts. Are there other particular benefits beyond health or special ethical priorities even that need to be highlighted as part of the thinking around this particular intervention? So this is what we're going to be kind of continuing to improve on. This is an area where you can't open up a cookbook and figure out exactly what's the best way to ask these questions, to integrate them into the work, to help decision makers see them and make sure that they are thinking about them. But we actually do view ourselves as an important laboratory for health technology assessment groups around the world. And we hope that we can continue to learn and improve this aspect of our work. All right, but just by the way, to make it as concrete as possible, we do share this slide in our training of our appraisal committee members. Again, when they're asked to think about overall value for money at the current price, we obviously do believe that cost effectiveness creates an important foundation or anchor, if you will. We've always stressed the idea of there being a range because there's no one bright line in the sand that by itself can or should serve as a decision-making point. And we've framed our range actually going north, higher, from the point at which academic research suggests should be the maximum amount that we pay for better health with a new treatment. The idea being that every time we add new cost to the system to get good health outcomes for patients who can do better with that treatment, if we pay too much for that health, we have an impact through rising healthcare costs that has been shown to lead to people self-rationing care and also importantly dropping out of the health system. And just with data looking at people who drop out of the health system, out of insurance because of rising healthcare costs, academic research suggests that that threshold point, the point at which we can price up to, but not beyond, to make sure that we're not doing more harm than good, is much closer to 100,000 per QALY in the academic research. Now, we tend to use the equal value life year gained as the anchor for our pricing recommendations. So that's what's shown in this slide. So just to note that our range starts at that 100,000 and goes north a fair amount. And that was always intended to reflect the fact that we knew we weren't going to be able to quantify everything, that there might be special circumstances, these things like benefits beyond health and special ethical priorities that we would want to consider as we potentially go higher than that threshold when considering what a fair price would be. So that has always been a part of what we have been intending to do with our reports and with our messaging to all different stakeholders. And I just thought it would be helpful to reflect on that again, since we continue to work on all aspects of this. You know, what are the thresholds that should serve as the boundaries of the spectrum? And how do we make sure that we capture, reflect, and make as tangible as possible in decision-making other elements, these benefits beyond health, special ethical priorities, and within that, you can fit every single petal of the ISPOR flower if you're familiar with that argument. So let us continue forward to talk more about the cost effectiveness. Okay, there's a lot, again, when you look at the methods around cost effectiveness, we have a very detailed, what's called a reference case for health economists to really kind of get the blow by blow. Here are some of the key aspects that we've been thinking about, and we did get a lot of very helpful public comment. So we had been somewhat frustrated, as I kind of mentioned before, when we do an analysis, we do one that's kind of looking just at the effects, both costs and health inside the healthcare system, and another that's meant to try to look at spillovers into the societal aspects, like ripple effects, if you will. And for almost all purposes, the predominant or most influential element of that ripple effect has been viewed as productivity. Not the only one, but in many ways the most influential. And as I mentioned, that data are almost never included in clinical trials. They never, rarely will they actually measure that. And so health economists, being conservative by nature sometimes and not wanting to give value to one side of the equation when they can't put it on the other side in some way, have often viewed that with that much uncertainty, you would want to put a 0 in for the effects on productivity. But there has been recent academic work that we've been tracking, and we thought it was persuasive enough. It's now been peer reviewed, and we wanted to move forward with it, and we are. So we did receive some public comment on this issue, but we are going to move forward with a way that basically crosswalks from the health effects that are measured into a productivity effect, both for patients and for caregivers. And in general, you can consider that better health means that you're able to work better, if you will, either more attendance at work or better performance when you're at work. Now, to be fair, we got some concern from public comment, and this goes back a long way, that when you value productivity effects, you may be in a maybe not too subtle way disadvantaging treatments for conditions where people start out with a long-term disability, and no matter how much better they get, they will have that long-term disability. So they are never going to return to what a health economist might consider to be full productivity from an economic perspective in our workforce. But there are lots of reasons. So there are lots of reasons to consider this carefully, and not to say that we want to absolutely every time consider productivity as a driving part of value, because then we tilt the scales towards conditions of young working populations. This also affects elderly, not just disabled kind of populations. So we are continuing to be cautious and framing this as best we can. But we are going to include non-zero inputs now for productivity when we do our modified societal analyses. All right, when we proposed, a month or two before, or a couple months ago, what we would be changing, we did propose doing what are called dynamic price scenarios. What do we mean by that? That again is the assumption that the cost, let's say it's a drug, the price of a drug might go up after it's launched. In the past, it might go up a lot, but then at some point it might face generic competition, and it might have a price decrease at that point. And again, health economists around the world have very rarely tried to model that because of all the uncertainty about whether it will increase in price, and if so, by how much, and then when it will drop in price, and if so, by how much. And there are other conceptual reasons that health economists sometimes feel that it's not the right thing to do to even try, because you're making the decision today. And if you're willing to accept too high a price today based on some potential promise for a price decrease later, you're doing harm today by overpricing, and thereby, again, harming patients that you will never see, but who might have to drop out of insurance, et cetera. And that's a questionable public policy position, to do harm today to maybe get more benefit later, when maybe the social contract should be never doing harm. Let's pay only up to a fair price today where we do no harm, and then yes, society will get a better deal later. So you'll hear lots of arguments about this. Here in the States, we have the Inflation Reduction Act and the new Medicare drug price negotiation provisions, which, if they stand, at least in Medicare, will address that price increase, which will essentially be capped to inflation. And then, or at around 10 years, either there will be generic competition, or it's very possible that the drug will be negotiated. So we want to make sure that we capture this in a way, and we are going to be doing these scenarios But in getting feedback, we've heard from health economists and others that it's really not clear, even if you want to do this, how exactly you operationalize it. So we are going to be working with our group of health economists, our external kind of consortium to advise us, and doing some pilots on this before we launch any kind of formal dynamic price scenario in our reports. But you will see this, it just will be more on a pilot basis as we make sure that we learn and get this more or less right, if you will, before we make it a formal part. The last here is on GRACE, where we are going to think about the GRACE network. I don't have time to get into the details here, but you can consider GRACE as one of the broad set of issues of whether we want to modify our thinking about health according to how serious patients are with their condition at the beginning, whether there are elements of how we feel about risk of having a very serious condition, and whether we think that it's much more important to get a little bit of health gain at, starting down at the bottom of, kind of functional status and quality of life, or nearer the top. GRACE is a technical method that has been introduced very recently, is not well known by health economists, is not used by any health technology assessment group internationally, but we understand that some of the international HTA groups do have some mechanism for weighting the health gain by the level of severity. We have used that more as a piece of our special ethical priorities kind of consideration. So we're going to look at this as a more quantified approach, but we need time. I think needs time to both think further about the validity of this approach, many of the operational aspects. So again, we're going to be deep diving into this with external economists and others, and we'll be iteratively deciding if and how we might integrate this into our work. All right, so I already talked about these issues. I'm going to go rapidly through these slides since I've already kind of described them, and I want to make sure that we have time to close up. But basically, the key features here are that for dynamic price and GRACE, we are going to be taking a period of time. We don't know exactly how long it will be, but we view these as important elements of our future methods to consider and to, again, learn more before we launch out ahead of the curve. We're always trying to learn and be a laboratory, and we do try new things, but we always have to be somewhat cautious of unintended consequences. So we're going to be thoughtful because these do have potentially major effects on both the methods and the results of cost effectiveness. By the way, this work with GRACE will, the last bullet here is key because we're going to be working not just with academics, but with others, because like other methods of cost effectiveness, this may raise some questions about potential discrimination and about fairness across patient groups. To be clear, there are rarely any methods that create only winners. There are frequently winners and losers. And so people have to be very thoughtful about the implications, for instance, of telling some patient groups that their health gains might be weighed less than others because they are considered to be less seriously afflicted. So we'll be working on all this and looking forward to the external kind of engagement on this as we go forward. All right, and I'm going to hand it back over to Sarah to close this out. But thank you again for your attention and for all the input that we've had throughout the last 3 years, the public comment and the comments we'll get going forward. Sarah?
Thank you, Steve. My thanks to Felucio and Kat as well. And the reflections here as we wrap up are to first thank all of you, for the people on the webinar today, for the people who have watched this on a recording, and for those who have contributed to our thinking. So that's the over 30 organizations that submitted formal public comments, for the organizations that partnered with us in small group discussions while we debated some of these updates and changes, to the international HTA organizations that have shared their thinking as some of these issues have evolved. We do this work and we do our value assessment framework so that we have a transparent guidebook for every single assessment. So it's very clear what we're doing and how we're doing it. And Kat did a beautiful job talking specifically about sort of how we can engage different stakeholders throughout that process. This is because of our commitment to transparency. You don't necessarily have to agree with every single thing that we do and believe in to engage with us. We value the engagement of people who disagree with us. We think it makes us better. We are always learning. And so you have our deep gratitude for the time and the energy that you spend to engage with us and give us these ideas. As we wrap up today, I can't help but mention that hopefully everyone saw yesterday the very exciting news that Dan Ohlendorf is returning to ICER as Chief Scientific Officer and Director of HTA Methods and Engagement. Dan and I are first very good friends, but also colleagues dating back to my first days at ICER in 2009. And with Dan's arrival will be a next chapter for how we are thinking about evolving our methods. Steve did a beautiful job talking about grace, talking about dynamic pricing and how we need to learn. And Dan's leadership, both domestically and internationally, on all things value assessment is going to be an incredible complement to our already outstanding staff. So with that, an invitation to keep engaging. We welcome feedback, questions, anything that we can clarify as we start to launch reviews using this updated value assessment framework and already start the work to think about what we will change between now and our next update. With that, I thank everyone for their time and attention, and that concludes today's webinar.